Hey all, Dr. Huston here with the University of Kentucky Department of Anesthesiology, perioperative, critical care, and pain medicine. As pretty much any of the residents here know, I'm one of the critical care attendings, and today I'm going to be doing a lecture on ventilators. So, a few things we kind of need to cover, the basics. We'll go over these various definitions of assist control ventilation, single mode ventilation, which is your volume assist control and your pressure assist control, your dual control modes. Typically, we think of PRVC. That naming convention may change based on the manufacturer, but it all works pretty much the same. SIMV, synchronized intermittent mechanical ventilation, and then pressure support. So, kind of start with the most basic stuff. Assist control ventilation. So that can be volume assist control or pressure assist control. And we can kind of break that down even further. So control, the physician will have the ventilator deliver a set number of breaths. That is the control of assist control ventilation. The assist is the patient may take additional breaths from that set rate. And when the patient triggers, we'll get to that later, the ventilator will deliver a full breath, and that's going to be based on either volume, if you're in volume assist control, or pressure, if you're in pressure assist control. So the patient will just have to trigger the ventilator, and the vent is going to do the rest. So, kind of definitions continued. The parts of the mechanically ventilated breath are the trigger, the limit, and the cycle. And we'll kind of break each one of those down during this lecture. So, trigger. That is, how does the patient let the vent know that the patient wants a breath? So, the ventilator senses a change in pressure or flow from the patient's effort. First thing we'll talk about is pressure triggering. So, pressure triggering requires the patient to drop the end expiratory pressure a certain amount. Usually they're going to have to drop it 1 to 4 centimeters of water. So if you have your PEEP set at 5 centimeters of water, your trigger set at 2, so the patient has to drop that pressure from 5, drop it by 2, down to 3 centimeters of water. Then the vent senses, oh, hey, this patient is tugging at the endotracheal tube, trying to inhale, trying to take a breath, and it will assist them and deliver a breath. So kind of try to break it down here with this little schematic I drew. First off, note we have our pressure and time. Those are our axes. We have our PEEP set at 5 centimeters of water. We have our trigger set at 2. So that means the patient has to drop that pressure to 3 centimeters of water. When the vent senses a pressure of 3 centimeters of water, 2 centimeters below its normal PEEP of 5, it says, oh, the patient just tried to trigger a breath. I'm going to help them out and fire off a breath. So as you can see here, we have an effective trigger. The pressure, the patient tugged, trying to inspire, dropping the pressure from 5 to 3, and the vent fired off a nice breath. Okay? You can note here we have some ineffective breathing. You see the little dips. The patient is attempting, most likely the patient is attempting to take a breath, but they can't generate enough negative force to drop us all the way down to 3. All they're doing is dropping us 1 to 4. So the vent does not recognize that as an attempt at a breath, and so it doesn't give them a mechanically ventilated breath. Until here, they finally drop it again, and we fire off another breath. You can also have flow triggering. Let's see here. Pretty obvious to look at the vent, your pressure and your time curves, or graph, and see when breath gets triggered, right? Pretty easy to see here. Start off here with flow triggering. It's going to be a change in flow. Normally, on any inspired breath, the flow goes into the patient, and we have a flow trigger right here. How do we know? Because our flow trigger is usually like 1 to 6 liters per minute. It's really small. next page, we'll get to this, but kind of noted here, this is so small, how can we tell? But what we do is we're going to set a flow trigger, usually 1 to 6 liters per minute. The patient needs to pull that kind of volume into the endotracheal tube, and the vent senses, oh, this patient's trying to take a breath, I'm going to help them out. So right here, the patient is not breathing, we have just 0 flow right across here. Now the patient attempted to breathe in, they breathed in whatever that flow needed to be, they hit their flow trigger threshold here, and then the vent kicked in and was like, hey, I'm going to help you out with this breath. So flow trigger continued. We know this is really small right here. So on the vent, you see a nice change in color. That change in color means the patient attempted to trigger a breath, or was successful, I should say, at triggering a breath. This was a patient-triggered breath right here. We see that nice change in color. If the next breath was, let's say, just green the whole way, we could probably safely say that this was entirely machine or vent triggered, and the patient did not initiate that breath. Either they didn't meet the flow trigger or they didn't even try. Little more. Flow trigger continued. Cool, it's great. Now we know about flow triggering, but how exactly does the vent sense this? Well, the ventilator is actually going to have a bias flow flowing through it throughout all times. So the vent circuit actually has a constant flow going through it during the non-inhalation phase. So when the patient is exhaling or the patient is not making any effort at all, the vent is actually pushing 5 liters of air through the circuit. And if the patient is not attempting to breathe at all, nothing is going into the patient, pressures are equal, so 5 liters goes out of the vent and 5 liters should come right back into the vent. However, if the patient attempts to trigger a breath, of those 5 liters going out, let's say they pulled 3 liters into their lungs, and so the vent only gets 2 liters per minute of flow back. And as long as your flow trigger is set correctly, the vent is going to sense, hey, this is clearly the patient trying to trigger a breath. I'm going to help them out and fire off a breath for them, with them, I should say. A few more triggering notes. Flow triggering, it actually takes very little effort. So our normal mean inspiratory flow of a person at rest, you and me just breathing right now, is roughly 15 liters per minute. And that peak flow, like at the start of our inspiration, like if we just take a nice deep breath right now, we start off breathing pretty fast, and that's actually closer to 30 to 35 liters per minute. And remember, we set our flow trigger somewhere between 1 to 6 liters per minute. So quite a bit less, pretty sensitive. Few problems we can run into with pressure triggering. You need to be cautious with patients with COPD or asthma. They can auto-peep, and then they have to create a very negative pressure to trigger a breath. What I mean by that is we'll kind of go back to how we had our previous one drawn. We had our pressure of 5 centimeters of water of PEEP. We said they had to drop it to 3 to trigger a breath. Once we hit here, that 3, the vent senses the patient trying to take a breath and fires off a breath. Now, what happens if they have COPD or asthma and they're not given enough time to exhale? They slowly start to auto-peep. Let's say we get up to here. Now we've got a PEEP of 10. Our flow trigger is still at 3. So now they have to create negative 7 centimeters of water to fire off a breath for the vent to sense that they finally got back down to 3, which is pretty hard to do. So caution in pressure triggering with COPD and asthmatics. Flow triggering, on the other hand, is very sensitive. It is, in fact, so sensitive that you can have fluid build up in the circuit, and the oscillations back and forth of that fluid can be sensed by the vent, and the vent will trigger breaths. So, let's see, we got our vent circuit. We got our fluid, secretions, whatnot, junk building up. any sort of breaths in and out, oscillations of the circuit going back and forth can actually move our liquid back and forth, and the vent can sense that as movement, as a change in flow, and think that the patient's trying to breathe. I've actually had patients where I've suspected them to be brain dead, and nursing will tell me, oh, they're actually triggering their breath. And it is, in fact, them not triggering. It's actually the flow trigger being set very low, and fluid secretions built up in their firing off the ventilator. So you can switch them to a different setting, increase the flow trigger, or just switch them to a pressure trigger and see if, in fact, they are breathing. Okay, so that was the first part of the breath we talked about, the trigger. We'll do a pressure trigger because it's easier to see. Now we're going to talk about the limit. So trigger here, limit is kind of this whole period, how much of a breath we want to give the patient. Then our last part will be the cycle when we want to terminate the breath, but we'll get to that in a little bit. Right now we're going to talk about limits. So a limit is essentially how much volume, if you're in volume assist control, or how much pressure, if you're in pressure assist control, you want to deliver to the patient. Remember, these are single variables, so volume assist control will give a constant volume regardless of the pressure needed, and pressure assist control will give a constant pressure regardless of the volume given, either big or small. Advantages of this, it's fairly easy to monitor lung compliance and function as things change. Disadvantages, it's easy to do harm if you're not paying close attention. Personally, I'm a pretty big fan of pressure assist control. Let's say I have my pressure assist control at 12/5 for this patient that came in with pretty bad ARDS. Just making up some numbers here. At 12/5 today, they're getting tidal volumes of 250. Okay, tomorrow, I still have them at pressure control, 12/5. And now they're getting tidal volumes of 350. So I can say that their lung compliance has improved and they're probably starting to get better. Fantastic. I can actively watch how a patient is recovering. But let's say I'm not paying close enough attention. I'm 12/5 today, tidal volumes at 250. The patient has this fantastic recovery. They're still at 12/5. Nobody's checked in on them on the vent. The next day, they're now getting volumes of 650. Well, now we're starting to worry about trauma and giving way too big of tidal volumes and doing damage. So easy to do harm if you're not paying close attention, but also very nice to be able to follow lung mechanics as recovery or digression may occur. A few more things on the limits. Volume assist control. So the ventilator is going to deliver a constant flow until the set tidal volume is reached. Then it's going to terminate that gas delivery. So you get this constant flow, immediately go up to the flow, stays constant until we terminate the breath, and we drop back down and the patient exhales. And as that flow goes in, the pressure is slowly going to increase over time. Okay? Pressure assist control. The ventilator goes up to a set pressure and then holds it until it is told to turn off the flow. That's your I time. I time just stands for inspiratory time, and the physician sets this I time. Sorry, one sec. All right, so that was your single control modes, your volume assist control and your pressure assist control. We also have dual control modes. The best of both worlds? Maybe. This is classically your PRVC, aka SIMV, aka VC+, aka whatever the manufacturer of your vent decided to call it. So how these work is the physician or RT enters a tidal volume, a rate, a respiratory rate, and an I time. The ventilator will then give the patient this tidal volume over the set I time, adjusting the flow throughout the breath to get the tidal volume in with the lowest pressure possible. It can also sense the patient's efforts and adjust accordingly. Sounds pretty great. Most of the time it is, but not always. Unfortunately, when the patient effort is not completely consistent, the patient can get widely varying breaths, i.e. if the patient took a nice big breath, the vent is like, okay, this next breath, I'm going to give them minimal support. But now the patient takes a small breath or gives minimal effort, and the patient ends up getting a tiny tidal volume and starts panting away and breathing quickly. Then you get called and you say, hey, the patient's fighting the vent. And in fact, they're probably not fighting the vent. They're probably just not taking consistent breaths. And you may be better off, instead of sedating them and paralyzing them, just switching their vent mode to something more consistent, like volume assist control or pressure assist control. SIMV, synchronized intermittent mechanical ventilation. So how this works is the physician sets the vent to deliver a certain number of breaths per minute. The patient can take additional breaths on top of that, but those breaths will not be supported by the vent, at least in the classical sense. Newer vents are quite fancy, and they can actually be programmed to give pressure support into those breaths. So the synchronization in SIMV is the vent sensing and synchronizing with the patient's expiratory efforts, so it won't deliver a preset breath when the patient is spontaneously exhaling. Makes it a whole lot more comfortable. It's a decent setting if the patient can take good tidal volumes on their own, but if the patient has ineffective spontaneous ventilation, it can lead to a high work of breathing. Like they're trying really hard, they're trying to breathe 30 times a minute, they're taking really small tidal volumes aside from the ones that the vent delivers them. They're working a lot, they're inefficient, it doesn't work out so well. Pressure support. This is where we are finally going to talk about the last part of the breath, the cycle. So let's see here. So let's go back. We talked about the trigger already. The limit, trigger, limit, and then the cycle. When do we want to cycle from the inhalation phase to the exhalation phase? So yeah, the patient triggers the ventilator, the vent supports the patient's effort with a predetermined pressure support, but when is the breath terminated? There's no set I time or tidal volume in pressure support, so how does the vent know when to stop giving pressure support? So the vent, at least in pressure support, is flow cycled. The pressure support is terminated and support is dropped back down to PEEP once the ventilator senses a drop in inspiratory flow to a certain percentage of the initial rate. It's usually 25%, but it can be adjusted, and I will attempt to explain this on the next slide with some drawings. Okay? Well, apparently the slide after the next one, but a little more on this. So when the patient triggers the vent, the pressure rises from the set PEEP to the set pressure support pressure, let's say 12/5. So let's say at the beginning of the breath, the flow into the patient is 40 liters per minute. The ventilator will keep the system pressure at 12 centimeters of water, facilitating gas flow into the patient's lungs, and that's going to continue until the inspiratory flow drops to 10 liters per minute, i.e. 25% of the initial flow of 40 liters per minute. Let's say we have it set at 25%. So at this point, the pressure will drop back down to the PEEP, and the patient will be allowed to exhale. So here's how we're kind of going about all this in pressure support. We'll say our pressure support is 12/5. So we're hanging out with our PEEP here at 5. At our PEEP of 5, our flow is 0 liters per minute. The patient's not attempting to breathe in. The patient then attempts to breathe in. They trigger a breath, and we give them that pressure support of 12. They breathe in. With that pressure support of 12, as they initially breathe in, air is flowing into the lungs at 40 liters per minute. That's our peak there. And the flow in slowly tapers off as the patient doesn't breathe in quite as hard, but we still are giving them that pressure support of 12 throughout here. And we will continue that inspiration and that pressure support of 12 until our flow rate drops to 25% of what it initially was which is 10. So once we hit that 25%, our vent's like, okay, this patient is done attempting to breathe in. I'm going to drop them back down to the PEEP of 5, and it allows the patient to exhale and return to this flow of 0 till the next breath gets triggered, and we start that whole cycle over again. Okay? That is flow cycling in pressure support. So, yeah, we just discussed flow cycling in pressure support ventilation, but all breaths must be terminated, so all breaths must have a cycle. Pressure assist control is time cycled, i.e., we set the I time. At the end of this time, the breath changes from inspiration to expiration. Volume assist control is volume cycled. Once the patient gets that predetermined volume we set for them, the breath changes from inspiration to expiration. There is also pressure cycling, which is essentially a safety feature. So if the patient generates a high enough expiratory pressure, i.e. they cough when the vent is trying to give them a breath, the vent's going to terminate that breath. You don't want the vent to try to override this massive exhalation from a big cough from a patient and just force more air into them. Just going to cause some barotrauma, make the patient very uncomfortable and very unhappy. So let's talk briefly about non-invasive ventilation. In many ways, it is quite similar to mechanical ventilation. Non-invasive ventilation, CPAP and BiPAP. A lot similar to our invasive vent settings. Trigger, a volume, give them a PEEP, give them a flow rate. Oftentimes start off with a flow rate around 60 liters per minute, and you give them a certain FiO2. You can pick the flow pattern, steady pressure, so you go right up to the pressure you want, you keep that pressure steady throughout the breath, and then drop it off. Or what's typically a little more comfortable is ramping up the pressure till they get the size of the breath they want. Good candidates for non-invasive ventilation: severe COPD exacerbations, pulmonary edema, asthma, Guillain-Barré, or myasthenia gravis. Honestly, that could be a whole nother lecture of when you would use non-invasive ventilation versus invasive ventilation with these patients and what your indications and when you would do that. But just keep in mind, it is reasonable in many patients to do with GBS or MG to do non-invasive ventilation. CPAP, great to use in hypoxic, non-hypercapnic pulmonary edema or use in severe pneumonia. Typically, your settings are going to start at 1 centimeter of water per 10 kilos the patient weighs, up to a max of about 10 centimeters of water. CPAP is just a constant pressure. It's just like this PEEP with nothing additional on top of that to help them inhale or exhale. So you're just stenting the airways open, hoping to increase your oxygenation. BiPAP helps eliminate CO2. So your settings on BiPAP are, you're going to also have your IPAP and your EPAP. Your IPAP being your inspiratory positive airway pressure and your EPAP being your expiratory positive airway pressure. IPAP's quite similar to the pressure support you give a patient on pressure support ventilation, and EPAP is pretty much akin to PEEP. Reasonable to start similar where you would start on pressure support, like 12/5, 10/5, something in there, and then you can go up or down based on how the patient's doing, what their ABGs are showing, what their monitors are showing, and all that. So both CPAP and BiPAP help with oxygenation. However, only BiPAP helps with the elimination of CO2. So in hypercapnic patients where you're hoping to get their CO2 down, you select BiPAP. All right, let's go over a couple questions here, and then we will call it a lecture. So we have a 73-year-old male, past medical history of AFib and COPD, who presents to the ED status post-stroke, intubated in the ED for inability to protect his airway. In the ICU prior to going to the angio suite, patient becomes progressively hypotensive with transient arrhythmias. The following graph is observed on the ventilator. What do you do next? So kind of important things in this question: COPD, progressively hypotensive, arrhythmias, hemodynamic instability, and then we are given the following graph. So this is flow over time, and what we see here is in the exhalation phase, we still have air flowing out and never returning to a zero flow state. So the patient is never fully exhaled, and you can see that with COPD. And so what is happening with this patient is they are auto-peeping, so much so that they are becoming hypotensive and having arrhythmias. Your solution to that is, let's see here, it's going to be D. Disconnect the patient from the ventilator, let them exhale all the way, and once the lungs are decompressed, hook them back up to the ventilator with different settings, longer expiratory time. All right. Which settings primarily influence oxygenation? PEEP, FiO2, or respiratory rate, or some combination of those? The answer here is PEEP and FiO2. These control your oxygenation, respiratory rate, and tidal volume, which makes up your minute ventilation, control CO2 elimination. So our answer here is D, A and B. And then one last question. A patient with known LV dysfunction, LVEF is 30% on recent echo, RV function is within normal limits, it's post-op day 1 from CABG, and they remain intubated. They have a PA catheter in place, which demonstrates a cardiac index of 1.2, which is low. Current vent settings are pressure control, 14/5, FiO2 of 40%. Which change could be made to reduce the work of the left ventricle and increase cardiac index? So decrease PEEP from 5 to 2, increase PEEP from 5 to 10, or increase our FiO2 to 60%. Well, increasing our FiO2, unless for some reason we think this is all ischemia related, isn't going to help. So that's not the correct answer. So now we can either drop our PEEP or increase our PEEP. And increasing our PEEP actually helps out our LV. So our LV does well with elevated PEEP. With increased PEEP, decreases the transmural pressure. So increasing PEEP is going to help out our LV. It could harm our RV, but this question we were given that the RV was just fine. So correct answer here is B, increased PEEP from 5 to 10. And let's see here. Oh yeah, so these are kind of a continuation of lectures from Dr. Shell for the ITE preps and whatnot, and he would end many of his with a cool photo of somewhere where he was or he and his family were. So here is a photo of me and my daughter on the Oregon coast from this last summer. And here are the resources I used and would encourage you to look at. All right, thanks a lot all.